नमस्ते बिटिया, हमेशा खुश रहो बिटिया। I am Dr. Bharat Sharma, Assistant Professor, Department of Pathology, Faculty of Homeopathic Science, JAYOTI VIDYAPEETH Women's University, Jaipur. Today's topic is urolithiasis or kidney stone or nephrolithiasis. Nephrolithiasis or urolithiasis is formation of urinary calculi at any level of the urinary tract. Urinary calculi are worldwide in distribution, but are particularly common in some geographic locations, such as in parts of the United States, South Africa, India, and Southeast Asia. It is estimated that approximately 2% of the population experiences renal stone diseases at some time in their life, with male to female ratio of 2:1. This peak incidence is observed in 2 to 3rd decade of life. Renal calculi are characterized clinically by colicky pain, renal colic, as they pass down along the ureter and manifested by hematuria. Types of urinary calculi. There are four main types of urinary calculi. First is calcium containing. Second is mixed stones. Third is uric acid stones. Fourth is cysteine stones. First is calcium stones. Calcium stones are the most common, comprising about 75% of all urinary calculi. They may be pure stones of calcium oxalate, about 50%, or calcium phosphate, about 5%, or mixture of calcium oxalate and calcium phosphate, about 45%. Etiology of calcium stone is variable. First is about 50% of patients with calcium stone have idiopathic hypercalciuria without hypercalcemia. Approximately 10% cases are associated with hyperkalemia and hypercalciuria, most commonly due to hyperparathyroidism or a defect in bowel absorptive hypercalciuria or in kidney, that is renal hypercalciuria. About 15% of patients with calcium stones have hyperuricemia with a normal blood uric acid level and without any abnormalities of calcium metabolism. In about 25% of patients with calcium stones, the cause is unknown as there is no abnormality in urinary excretion of calcium uric acid, your oxalate, and is referred to as idiopathic calcium stone diseases. Pathogenesis of calcium stones. The mechanism of calcium stone formation is explained on the basis of imbalance between the degree of supersaturation of the ions forming the stone and the concentration of inhibitors in the urine. Most likely, sites where the crystals of calcium oxalate and or calcium phosphate are precipitated is the tubular lining or around some fragments of debris in the tubule acting as nidus of the stone. The stone grows as more and more crystals are deposited around the nidus. A number of other predisposing factors contributing to formation of calcium stones are alkaline urinary pH, decreased urinary volume, and increased excretion of oxalate and uric acid. Second is mixed or struvite stones. About 15% of urinary calculi are made of magnesium, ammonium, or calcium phosphate, often called struvite. Hence, mixed stone are also called struvite stone or triple phosphate stone. Etiology of struvite stones are formed as a result of infection of the urinary tract with urea-splitting organisms that produce urease, such as by species of Proteus and occasionally Klebsiella, Pseudomonas, and Enterobacter. These are therefore also known as infection-induced stone. However, E. coli does not form urease. Uric acid stone. Approximately 6% of the urinary calculi are made of uric acid. Uric acid calculi are radiolucent, unlike radio-opaque calcium stones. Etiology is uric acid stones are frequently formed in cases with hypercal- hyperuricemia and hyperuricosuriasia, such as due to primary gout or secondary gout due to myeloproliferative disorders, that is, leukemias, especially those on chemotherapy and administration of uricosuric drugs, that is, salicylate. Other factors contributing to their formation are acid urinary pH below 6 and low urinary volume. Pathogenesis of uric acid stones. The solubility of uric acid at pH of 7 is 200 mg per deciliter, while at pH of 5 is 15 mg per deciliter. Thus, as the urine becomes more acidic, the solubility of uric acid in urine decreases and precipitation of uric acid crystal increases, favoring the formation of uric acid stone. Hyperuricosuriasia is the most important factor in the production of uric acid stone, while hyperuricemia is found in about half the cases. Cystine stones. Cystine stones comprises less than 2% of urinary calculi. Cystine stones are associated with cystinuria due to a genetically determined defect in the transport of the cysteine and other amino acids across the cell membrane of the renal tubule and the small intestinal mucosa. Pathogenesis is the resultant excessive excretion of cysteine, which is least soluble of the naturally occurring amino acid, leads to formation of crystal and eventually cystine calculi. Other calculi less than 2% of urinary calculi consist of other rare types such as due to inherited abnormalities of enzyme metabolism, that is hereditary xanthinuria, developing xanthine stones. There are some morphology of different type of stone. This is calcium oxalate stone. It is staghorn stone, also known as struvite stone or triple phosphate stone. It is uric acid stone, and this is cystine stone. Renal calculi increase incidence in male. Symptoms are nausea, vomiting, agonizing flank pain, may radiate to groin, testicles, abdominal area, sharp, sudden, severe pain, hematuria, dysuria, urinary frequency increases, ultrasound caused diagnosis, IVP, renal stone analysis, KAV of X-ray, serum calcium oxalate, uric acid. Risk factors and etiology are infection, urinary stasis and retention, immobility, dehydration, uric acid increase, and increased urinary oxalate. This session is powered by Digital Version 2.0 JAYOTI VIDYAPEETH Women's University. I hope you all enjoyed this session. If you have any query, please mention it in the comment box. Thank you.